Good morning from WFLHCA. Welcome to our weekly webinar. Today we're going to present some cases that are involved with our Care Assure program that has nurse navigators within the hospital. We are able to identify patients that are high risk for procedures and navigate them in the hospital, outside the hospital, after they go home for clinic appointments, etc. And so it's a good program. And so we are interested in identifying patients not just as they come in the hospital and have abnormal EKGs and abnormal echoes. We're also interested in those that can be identified preoperatively from the office. And so we have two patients today we're going to present that we've identified as high risk for the office that are good patients for navigating in the hospital when they have surgery. Let's talk about these patients. And so the case of the bladder prolapse, questionable coronary artery disease. And so elective perioperative cardiology involving orthopedic surgery, pelvic floor surgery in seniors. And these are people that meet the same demographics as my cardiac patients in the office. As a matter of fact, many of them are my cardiac patients in the office. As they age, they have hip surgery and knee surgery. They develop complications. They have pelvic floor surgery. And so we're looking at this group of patients and talking about how to risk stratify them. Are they any riskier than other people? And so we've got people with hypertension, clotting, bleeding, pacers, histories of VT, on arrhythmias, on antiarrhythmics, paroxysmal atrial fibrillation, stents, hypotension, and so forth. So let's look at some of these patients. And of course, historically, I've found some patients that had some problems, this is someone who died post-op from bleeding. Apparently it still happens, and here's somebody that bled and was discovered in rehab by the general practitioner and missed by the PA rounding for the orthopedics. Orthopedic hip surgery has gotten to be a big deal now. It's bundled. And so Medicare is looking at the cost, trying to pay less, and groups such as hospitals and orthopedic groups are taking this on as a burden and looking at how they can cut their cost, how they can save money. And so they're lining up patients, 15 in a day, to get their hips done or knees done, or hips and knees. And so you may have someone with significant disease that's lost in this shuffle, and those are the outliers. And so I'm trying to discover the outliers, move them from a cafeteria medicine type operation where they have 15 lined up for the day, move them into Memorial Hospital as a boutique hospital and do the surgery and navigate them and have careful follow-up within the hospital by a cardiologist or appropriate specialist so that we don't get those complications. And it turns out that the people who are doing the cafeteria approach are more than glad for us to pluck out those who are high risk and do those separately. So this is an interesting program. We'll see how it develops. And of course, the hospital that's taking care of the mass group doesn't want to have the outliers, because if they have the outliers, they have to figure out how they're going to get compensated, especially if you have somebody gets atrial fibrillation, then gets anticoagulated, then winds up bleeding into their wound, then dehisces, then gets infected, and the whole pathway mounts up to $1 million in no time, and then they're in rehab. So how do you deal with the outliers? And so that's interesting, and we're going to talk about that a little bit today. And one of the patients we're going to talk about, our second patient, is pelvic floor antithrombin 3 deficiency, protein C, protein S deficiency, recent CVA, mitral valve repair, questionable PAF. So let's go look at our first case. Is an 81-year-old female with bladder prolapse, third operation for bladder prolapse surgery. Last was with mesh in 2013. 20-year history of hypertension, average blood pressure 140/75, on treatment, which is kind of a puny treatment, amlodipine 5 milligrams daily. Increased cholesterol and simvastatin. Everybody's still on generic simvastatin, And of course, you know, generic simvastatin was the first of the drugs that went generic that are statins. And it turns out this one has more overlay with other medications because of P450 metabolism problems. And so there's a lot of drug interactions. I would recommend switching to the latest or one of the other generic medications, which basically Lipitor and Crestor both went generic, rather than use this because it was the first one to go generic. So because you have to always check on drugs that it's associated with to find out which ones it might be interacting with, whereas you don't have to do that as much with the others. This patient has a 3+ family history of mom having a heart attack at 72, father at 69, and brother at unknown age. So history is laden with heart disease. For me, this is the #1 risk factor. If you've got all this, that's very, very important. More important than diabetes, hypertension, increased cholesterol, cigarette smoking. Denies chest pain, shortness of breath, dyspnea on exertion, PNDR, palpitations. No diabetes, no cigarette smoking. Risk factors for developing pelvic organ prolapse include age, parity, obesity, chronic constipation, hormonal status, previous gynecological surgery, hysterectomy, chronic obstructive airway disease, smoking, high impact activity, and genetics. And so these are the risk factors that are resulting in this patient having to have pelvic organ prolapse surgery. Let's look a little bit about that. I think it's important to understand the surgery that someone's having in order to understand the risk. And so this is a cystocele type surgery, major health concern, especially in the elderly. More than 200,000 operations are performed annually for pelvic organ prolapse. It's very hard to find experts in this area. A couple years ago, we queried and found 2 in the state of Florida. The doctor that we're associated with is an expert who'll be operating at Tampa General Memorial and Sarasota Memorial. So people who've had surgery 2, 3, 4 times are looking for someone like this. They've had surgery by sort of a general urologist for a cystocele, and this one's had surgery 3 times, and now for number 4. And they want that to be definitive. Reoperation rates, 30%, 60%, depends. Anterior vaginal wall prolapse, the most common form of female prolapse of organs, pelvic organs. 81% of prolapse repair include the anterior vaginal wall. Further, anterior wall carries the highest risk for recurrence with reported recurrence rates. Here we got 41%. Some of the recurrences won't be operated on, so the recurrence operative rate might be 30% because 11% might be able to get by without repeat surgery. So cystocele representing anterior vaginal wall prolapse. And so let's look and see what else we can find about this. And it may be asymptomatic, especially in early stages. You may feel a fullness or pressure in the pelvis, protruding lump from the vagina, lower back pain or pressure, problems with bladder emptying or bowel movements, dyspareunia, or vaginal bleeding. So urinary symptoms are very frequent with frequency and urgency, urinary incontinence, stress urinary incontinence, difficulty avoiding, urodynamically diagnosed bladder outlet obstruction was found more frequently with higher stage cystoceles than with lower stage cystoceles, not bowel movements, but bowel movements, dyspareunia, and vaginal bleeding are problems. So indications, prolapse repair is indicated for relief of patient's symptoms, restoration of normal anatomy, function of the pelvic structures, prevention of prolapse recurrence, repair of concomitant intrapelvic defects. Should be offered to all patients who are symptomatic, good surgical candidates willing to pursue surgical treatment. Cystocele associated with bladder outlet obstruction is also an indication for surgical correction. And so here's the mesh that is frequently used, and there's some question about whether this is a good thing or a bad thing. Apparently mesh is being used more and more. Current evidence that I found did not support the use of mesh repair compared with native tissue repair, but if you're having this for the 3rd time, this may be all you can do. And so it's increased morbidity, that means inflammation, and it means infection. So those are the concerns with that. And these are the guys that wrote about it. And so mesh is being used a lot. That's why it's being studied a lot. And here's an example of mesh being applied and sewed into place. It can erode into the vagina, can be a problem. So knowledge of available surgical materials and reconstructive gynecological surgery is important for surgeons and patients. Wise choices facilitate and enhance reconstruction surgery. So this has been brought up because of the use of mesh and complications from mesh. And so new materials or technologies that have not been scrutinized in appropriate clinical trials risk excess failure rates. Such trials should be relevant to the specific clinical situation and not generalized results from animal studies or non-gynecological human studies, such as orthopedics and dental surgery. Surgeons play an important role in requiring appropriate clinical trials before bringing in new surgical materials, i.e. mesh, into the operating room. And there are many, many different kinds of mesh, tight mesh, loose mesh, different kinds of metal as well. Finally, it's important that patients be informed about materials that are to be used in their reconstruction. So letting them know so they can go on the internet and find out what some of the hazards might be of inflammation and infection. Cystocele repair is contraindicated in the following patients: patients with local vaginal diseases, patients who are not surgically fit, and that's where we come in our decisions. They're not willing to undergo surgery, well, that's for sure. Patients who have early stage asymptomatic cystocele, watch and wait. So we have articles that are pertinent, and this is one that I thought that was the most pertinent: prolapse and incontinence surgery in the older woman. And cardiovascular risk factors most strongly associated with post-operative complications include a history of coronary artery disease, peripheral vascular disease, congestive heart failure. The American College of Cardiology, American Heart Association Task Force for Perioperative Evaluation recommend performing a clinical history, evaluating surgical risk, as well as assessing exercise tolerance, which may not be always positive and may not always be available to use in this age group where exercise intolerance, ability not to exercise, may not be available for them to exercise. And so we have to decide, what are we going to do instead of exercise? I will give you the option of coronary CTA as an alternative. In fact, older women have been excluded from many of the trials that have examined the outcomes of pelvic floor surgery. Well, obviously, because it gives you better outcomes. So why publish the older women? A systematic review found that the median percentage of women aged 70 or older who participated in surgical trials basically was 3.8%, while the number of surgeries performed in this population of women is estimated at 16%. So again, the age population that we're examining here is poorly represented in randomized clinical trials. So we have to take that in consideration. Fortunately, the mortality rate from prolapse surgery is 37 per 100,000 cases. I'm not sure I would agree with that, but that seems like an underestimation of anybody undergoing anesthesia, especially in this age group, but I guess it's all ages. So our workup in this particular patient is, of course, an EKG with poor R rate progression, which is a insensitive test for apical MI. And let's say it's sensitive, but it's not specific. And so we have many, many people with poor R wave progression that are being read as possible old anterior wall MI that certainly have never had an anterior wall MI, and we can show that echocardiographically. And then nonspecific changes are kind of a useless diagnostic EKG finding because they're not actionable. And so both these EKG findings confuse issues. One is not actionable, the other is poorly specific. So the echo is normal, so that overrules the poor R wave progression being indicative of a septal MI, and not really septal because the MRI shows that those are apical MIs. And so there's never been good geographic correlation of what we're reading on Muse GE EKG programs, the one specifically by Dr. McFarland, Peter McFarland, and what really correlates with MRI being an apical MI rather than septal. So that's neither here nor there. CIMT, non-calcified non-obstructive plaque, which is common 80-year-old ladies as well as common in now late 30-year-old ladies have non-calcified non-obstructive plaque very commonly. And so the severity of coronary artery disease is defined in several ways, including the following. And so we got anatomical, and that's the way I choose to start with. And then we got functional, which can be added to anatomical with FFR and FFM. And so we estimate blood delivery to tissue supplied by each branch vessel, which is the FFM, functional myocardial basically percentage. And so we can do, and we can actually have an ability on branch arteries, and I'll bring that up because we're going to be discussing that, of being able to tell you how much muscle is subtended by a branch artery based on how long the artery is. So, and then clinically by determining what symptoms correspond to inadequate blood flow delivery with what level of activity causes them and what relieves them, the pattern of recurrence, which is less reliable in the elderly because their activity is much more limited. And so if you've got bladder prolapse, you may not be, doing long walks. And so, and similarly, our patients that we're seeing that have hip surgery aren't going to be doing long walks either. So we got to come up with another way other than clinical. So you got anatomical and functional, and I'm choosing anatomical, and I'm trying to also glean functional from the anatomical with FFR or FFM. And so let's look at our CT on this patient. We're going to go to the CT in just a minute here. And let's see, well, we got the echo first, so we can look at the echo first. And so here's our echo. We've got a normal sinus rhythm for sure. We'll look at the echo first. A little TR. Some diastolic dysfunction, which is to be expected. This age group, normal for age. We can roll through this, go forward or backwards. Nice LV contractility, nice RV contractility, and no real pathology identified here on our echo. So now we'll go to our CT. And so hang on. So let's look at our CT scan on this lady. So usually I do a 3D volume rendered image review to start with. And so you can see we've got some stuff hanging on here that didn't come off with the segmentation, so we can easily segment that off so that doesn't get in the way. And so there it goes. So now we've got myocardium to inspect, and we can look at whatever artifacts we may have to deal with. So what I do when I look at artifacts is I'm interested in finding artifacts from segmentation. And so to do that, you've got to see what the segmentation is and where it could be causing artifacts. So here's a line of segmentation that are misrepresentation that was involved in taking these slabs or slices, of which there looks like there may be 4 here, and putting them together. So here's 1, here's 2, here's 3. If we had a faster scanner, we wouldn't have this problem, but we do with what we have, and 64 slices is the most common. So you can see an obvious misrepresentation or misregistration that's occurred here. or these are failed to align. And then you can see down here again a failure to align. And so let's go up here, and we've got this slice coming through here that comes on through here, but we're interested in this artery down here that seems to be sort of hanging by a thread. And so this looks like a diagonal and a branch of a diagonal, and that looks like that is below this misregistration line and above this misregistration line. So it's not an artifact, and so it's for real. So let's go through each one of these and take a look and see what we wind up with in terms of predictive value of risk. So we can go back over here, and we can see where we've looked at some of these already and pre-selected the images and taken pictures of them. So this is concentrating on the one that we thought that was the most important, which you can see it's pretty rich in necrotic core, which is all that red. The red is common as epicardial fat, and you can see there's an association, of course, with the amount of epicardial fat and underlying coronary artery disease, but there's a lot more fat that's in this lesion in the wall, and so we can see some prominence there. So let's take a look at this, and you can see the stenosis as we march through here. And so this may be a stenosis that has some risk because of the epicardial fat. So let's see how much we have here on the whole vessel in terms of fat that's managed to localize in this area of obstruction. And so we've got the wall outlining this. We've got this big fat globule here that's necrotic core. And so let's see what we get from this information. And so we've got 25.5% of this area here constitutes necrotic core. So that's not bad. What's bad is when you get 35%. And down here by volume, we've got about 25% as well. So again, not as bad as when we see 35%, 38%. But there is a lot of necrotic core, and it's focused. It seems to be somewhat close to the lumen of the vessel, which is another observation to make. This is not the usual convergent divergent double cone, because it is convergent and it is divergent, but as we see, there's a linearity of the throat of the convergent divergent double cone, and the throat is kind of long. So that's a little bit different hemodynamics than we're used to seeing in the rocket-like short throats that we see in patients. In the sort of rocketry convergent divergent double cone, the diameter stenosis measured 77%. We probably underestimate that. The length of the lesion is 7.9%. That's including the convergence and the divergence. And so the area stenosis is 95%. So we can take a picture of that and save that, and then go look at the other vessels. So let's go do that now. And we'll take this over here and hang on, and we'll see what else we can see about these vessels. So as we twirl them around, we see, well, there's some narrowing there. Maybe that has to do, and it doesn't seem to have to do with, we're going to see if that was related to this little line that we have coming through here, but it doesn't seem to be. And so we'll have to check that one. That one doesn't look as bad. We're looking at some remodeling, and you can see some positive remodeling that's occurred in these vessels, probably some calcification. And so turning this around. So let's go look specifically at other vessels. So we'll turn this back on again so we can look at this. And now we're looking at the left anterior descending. And as we move through the left anterior descending, we see that there is an area of calcification. It's positive remodeling, and it looks like the channel remains open through that area. So that's a good thing. And we're moving through here further, and we don't see any significant disease as we move out distally. So let's take a look at, we can go back to that area up here that we thought was a little bit narrow, a little bit further up, right there, and it doesn't look like it's much. And there's epicardial fat, which you don't want to confuse with necrotic core inside the vessel. So let's take this one and measure this a little bit, see what that looks like. And so we really don't get much narrowing here. Let's move this down as the standard. Let's move it down here maybe. And let's display this so we can see continuous diameter of this vessel. You can see it did start out bigger, and it did get smaller, and it did get bigger again, and then ran into a piece of calcification. But that's not 28% diameter, 45% cross-sectional area. So no big deal. We can actually move this down here a little closer, and there's really not much in the way of convergence and not much in the way of divergence, which seems to be necessary to have a hemodynamically significant lesion. And so let's look at some of the other vessels and see what they look like. So we can pick this one out here and look at it, which is the upper branch of this diagonal. And we can go up to the top of it, and it looks pretty good. And then we can come over here and pick up, that's probably a vein, and but this is going to be an artery here. So we can trace that back, and it looks pretty good, and there's calcium, but the channel remains open as we look at the calcification. Of course, calcium has the blooming artifact and looks a lot more than it really is, and unfortunately that obscures our view frequently. But when you do a cardiac catheterization, you'll find what seems to be an asteroid or a big hunk of calcium on the CT scan is actually just a little bitty bit of calcium, and it's just a streak on the coronary angiogram. But here we're going to take a look at the right coronary and see what that looks like, and try to bring that back up here. And we have it a little bit upside down, and but there it goes upside down. So let's start back up here and see what we can do with that. And didn't quite go where it's supposed to go, so we can move down here and see if we got it earlier, the right. And no, we don't have that, so let's pinch it again, and otherwise we'll have to trace it. So looking at the right, trying to get a better idea or concept of what the right is like. So, and that didn't make very good picture, so let's go over here and start proximally with the right and work our way down then. And here we go, coming down the right. Didn't quite get its origin, but we'll get there in a minute. And then it came way down there and turned and looked pretty good. So let's go over to an axial view and just trace the right there, because it might be easier to do. We'll take off the advanced imaging, and here's the right, and we're just going to trace it out. Piece of calcium, non-obstructive, and then we see the right going on, and it's a big right, and it's supplying posterior descending and posterior lateral branches, and it looks pretty good, so we don't have to worry about the right. And then we got the circumflex coming out here with the calcification. The circumflex seems to go a long way with this anterior, with this OM1 view here. And so now we've seen all the coronaries, and the left atrial appendage looks okay. The aorta has some atherosclerosis. You can check the measurement of the ascending aorta, and that's okay. Normal for a little bit of upper limit of normal for this lady. And so the myocardium looks good. So it looks like what we're dealing with here, we can go back here. It says she has a single significant diagonal lesion. That's a long lesion of narrowing, And so what is the risk of that now that we've discovered it? What's the risk of that during surgery? What was the chance of discovering something in an asymptomatic lady? And what's her risk during surgery? So let's talk about that, and we'll move on to our slides of pelvic floor surgery. So we have Dr. Choi, who's South Korean, and some of his colleagues in Baltimore and Boston who've done 1,000 patients who are asymptomatic, who are in the age group that I'm used to dealing with, usually about 50 plus or minus 9 years of age. And we're able to see that 22% of them, 22%, have some plaque, and perhaps 5% have greater than 50% diameter plaque. Of course, it's going to depend on what kind of patient you're seeing, what the group is and group composition, the age of the group, and the pre-selection. Even though they're asymptomatic, there's some referral bias, and it's going to be patients that are referred or that somebody picked up in a clinic somewhere. They're going to have variable risk factors. So some of the studies, Dr. Hartlich and I came up with 22% on people average age 47 who are military, SOCOM and CENTCOM people that we work with, many of whom are riding a desk rather than an airplane, and so we got 22%. Well, that's not much different from Choi. You got 22%, 5% obstructive, and Hadamitsky got 23%. Cho, not to be confused with Choi, got 25%. Camargo had a much more biased population of high-risk people, so there was a lot of pre-selections done at this group where they got 76%. So we're going to go along with the average of about 22, 23%, and the average of significant obstructive that is greater than 50 is about 5%. So that sounds right, unless you're pre-selecting greater risk factors. So single vessel diagnosed disease, angioplasty versus medical management. And that has been studied and was presented at the American College of Cardiology 1 year in New Orleans. And they showed angioplasty versus medical management didn't seem to make any difference if that was the sole coronary artery disease present. And of course, the bypass surgery also was kind of overkill. And so we didn't have anything to go on in terms of trying to be aggressive on these, and it sounded like medical management was a great idea. And we've got some other plans on this patient who's going to be switched from Tampa General Memorial because of Tampa General. It might be number 13 of 15 patients, and if something does happen perioperatively, it's not going to be readily recognized because of the large group and the low risk. And so we're going to take the high risk patient, pluck her out of the system, cafeteria medicine, put her into a boutique situation, get a navigator connected up with her, and see what we can observe at her, make sure she doesn't have a perioperative infarct. And so we could go back over here and measure the length of the lesion, because there is a correlation with the length of the lesion, the length of the artery that has the lesion. So let's go look at that and see what that correlation is. So I can come over here, and I can come over here, and I can lay out this vessel, make it bigger, take a look over here, bring this down. Don't quite have the vessel as much as I'd like to see, so let's come over here, get a little more of this vessel, like that, and then see if we got more of the vessel here. And it jumps, so let's go over here and pick up a greater piece, and maybe if I hit it up here, I'll get a bigger piece. And so it's getting the other one, not this one, so we'll come down here. There we go. It looks like we got it. So then let's take the length of this vessel. So we'll have to make it smaller to get it on the screen. And then we'll want to straighten it out to measure it. Okay, and then we'll see where we go distally. And it looks like distally would be down to about here, would be the end of the vessel. So it'll be down at here. So let's go back up here. Let's straighten the vessel out. And so here's a straightening tool that we used. And let's go get a ruler. And we'll start with the lesion. And we'll shoot right down. And it looks like this vessel, when we get to where we wanted to stop, is 36 millimeters. And the group, Dr. Choi and team in JACC this week, have been able to show that 73 millimeters is significant and basically is correlated with subtending a 10% amount of myocardial muscle, 10% of the left ventricle with 73 millimeters length of vessel. So we only have 36. It's about half of what we need. So that vessel would not be subtending 10% of the left ventricular muscle. So it's of low interest in terms of revascularization. So let's go back to our slides again after we made that determination. And aspirin after the patient goes home would be paramount. We have a second case that we thought we'd just throw in a little bit to talk about, and that's a 72-year-old female who is going to have pelvic reconstruction as well. And this lady has a mini stroke 3 months ago. We picked her up at 3 weeks post-stroke to observe her. She had monocular diplopia, dizziness, could not stand, while on Coumadin INR 2.4, she had a, quote, stroke. The CT was unrevealing. The MRI has been done, so we'll probably check on that before surgery, but she does have a history of being on Coumadin for 15 years after mitral valve repair, but remarkably, no paroxysmal atrial fibrillation. Bladder surgery, 1983 hysterectomy. Those are sort of expectations if you have pelvic floor disease. And stress spec was normal, which doesn't seem to mean much. Chest pain a couple times a year, protein C and protein S deficiency, ischemic colitis treated with Iserdil, hiatal hernia, gastric ulcers, pancreatitis, kidney stones, frequent urinary tract infections, which goes along with pelvic floor disease, and kidney stones, pancreatitis. And so the EKG was normal. The Zio over 13 days showed no paroxysmal atrial fibrillation and some brief runs of AV nodal reentry tachycardia, that is SVT, that weren't very significant or interesting. And then she does have some compromise of the mitral valve, post-mitral valve repair with a 2 centimeter square mitral valve area, which should be 3.5 to 6 centimeters squared. And so that's much smaller than normal, but not enough to make a lot of difference hemodynamically in our echo measurements. We don't have our echo. It was done in Winter Haven. We can tell you on our coronary CTA, which we do have here, and we can take a look at, and we can look at our mitral valve at the same time we do that. So let's go to our coronary CTA. Hang on for a minute. So here's our patient and the coronary CT, consistent with these patients aren't able to have much mobility, and so we're trying to do CT preoperative evaluation anatomically. Again, we always look at the misregistrations where the slabs came together so that we'll have lines that we can look at when we go over here to make sure that we're not misreading. And then we get this vessel up, which is a branch of the left anterior descending. And then the real left anterior descending has a long intramyocardial course, So it takes a dip in, then a dip out. And so we know that's not going to have any coronary disease because it never does. And then we can see some calcification opacity of this sort of diagonal branch here with some beads of calcium going down the vessel. And so we can come down here and look and see if there's any obstruction. And I might not be able to see in some of these spots. Looks like we can see the channel, and the channel looks good. So there's one place where it narrows down a little bit, not too much. So it looks like open channel to me. So that's pretty good. And then we can look at fragments of the left anterior descending because it's got the intramyocardial course, and there's one fragment that looks pretty good. And then we can come up here to the other fragment, and then we can examine the intramyocardial course, which is going to be normal because it always is. And then we can look at circumflex, and that looks okay, and it's a huge right coronary artery. Let's go to the right, and we'll scan down the right, and we'll pick up what we didn't get by using our pencil. And so we'll make our pencil stationary and bring it down the right. Looks like it bifurcates into perhaps posterior descending and then posterior lateral branch. We can come down this one and look at the posterior descending, and that looks fine. So this lady doesn't have any coronary disease, but let's take a look at her mitral valve since we know she got mitral valve repair. And let's get rid of the coronaries for now, and let's brighten this up a little bit so we can see it better. We'll come down here, and then let's look at our mitral valve. And so you see there's a ring, because there's usually a Cosgrove ring that's put in, or one of the other rings, Carpentier. And you can see there is some compromise of that area. And we can look in several views to see the same thing. So there's our mitral valve. Over here, there's our mitral valve. Hard to see the leaflets. This is diastole. Let's see what we can make out of the leaflets. And there they are. There's the papillary muscle. Looks like an adequate orifice. Depends on the number of the ring. Whether it's a 21 or 23 ring. But it looks like it's going to be an adequate orifice. Maybe a little compromised, but looks pretty good there. So we're not too concerned about that. We know that there is a decreased mitral valve area in this case. So then coming back over here, we've got mitral stenosis, we got the cardiac CT. Oh, there was a question of left atrial thrombus. Let's go back and take a look at that and see how valid that question is. And so frequently we have some stasis of contrast in the left atrium, in the left atrial appendage. And so there it is. We can't really see, and we have problems resolving that issue unless you wait 30 seconds and make another picture. And then you can see penetration of those crypts. And so I see very fine denticulation, and I see these little crypts here, but right in there it's a little tougher. And so that could be real, it could be stasis. And so we did do a TEE and found out that was okay. So false positive left atrial appendage, if you could take another picture like 30 seconds later, you could clear that out much better. But we didn't know to do that because we didn't find it until afterwards. And so that looks good. So let's go back and see the TEE, no thrombus. And where are we going? Well, nurse navigator again. How about bridging the Coumadin, considering her high risk, and then she's had a TIA in the last 3 months on Coumadin, you know, and she has several risk factors involved with this mitral valve. So let's look at individuals considered at very high risk. As you know, we're not bridging much anymore for atrial fibrillation, but individuals considered high risk. Let's go back and we'll define her normal sinus rhythm, so she's not atrial fib. but she is on Coumadin for her TIA. We weren't able to demonstrate atrial fib. And so if you are high risk, then you can have a bridge. We don't routinely bridge anymore. And so, or if you're going to be a prolonged post-op period during which you won't be taking oral anticoagulants, you can have the bridge. So a couple reasons for a bridge. So I think we'll bridge her. What happened to the last case patient that we sort of bridged? And that was a patient who got Coumadin. They stopped the Coumadin for surgery. Post-surgery, this lady that was on Revlimid, multiple myeloma, and previous thromboembolic disease, and has a 100% chance of having a post-op clot. And so a little over-exuberant was the use of Xarelto as a bridge. I wouldn't recommend that. There's certainly more bleeding with Xarelto than there is dabigatran, or than there is with Eliquis. And so, and you can't get out of it very fast because it's a longer acting non-conventional anticoagulant. So the patient bled at the op site, and we had a poor outcome. We had staying in the hospital for an extra 3 days. Not a good idea. I think I would have used Eliquis, or I would have used something we could reverse, like dabigatran. I wouldn't have chosen the Xarelto, but someone to choose the Xarelto. So we do have, got to be careful of what our choices are post-op pelvic floor surgery. So thank you for coming today, and we hope to see you next week, and hope you enjoyed our presentation. Bye-bye.